All right, welcome to another episode of the Art of Med School. Today we're going to talk about GI bleeds. I feel like these have actually been coming up a lot for me lately. I have been doing a lot of digital rectal exams for hemocult, which I know, depending on what specialty you're in, is either silly or important, just depending on the literature you're reading. But today we're going to talk about GI bleeds. So starting with upper GI bleeds. So the most common causes, you got peptic ulcer disease. That's the most common. Risk factors are aspirin, NSAIDs, smoking, just kind of irritating that area. Erosive gastritis, esophagitis is another common cause. So you think about things like alcohol, salicylates, aspirin, NSAIDs. And then stress related from sepsis, trauma, or respiratory failure requiring ventilation. So if you ever do an ICU rotation, you're going to see that everyone is on like an ulcer preventative medication just to keep that tracked in check. And then like the really, really dangerous ones is the esophageal and the gastric varices. So these are like, you're thinking about portal hypertension, especially in alcoholics, they get those varices there. It's actually a pretty small percentage of bleeds, but this is a very, very high mortality rate. If you've ever seen a ruptured one where they are profusely bleeding out the mouth. Um, we had, it was not even a patient of mine. I just got asked if I wanted to intubate, and of course I said yes. But we had an unknown GI bleed that as soon as we paralyzed her to intubate, I was looking in the back of her mouth, and up came all this bright red and black mix, and it was awful. I ended up having to aim for where the bubbles were, and fortunately, I got it on the first pass. But this is a super common cause in alcoholics. It's the most common cause. Other ones that you're going to be thinking about would be Mallory-Weiss syndrome, so repeated vomiting followed by bright red hematemesis. Think about binge drinking, but also DKA or chemo. Anytime that you're vomiting for quite a bit, typically more than just like your regular old gastritis vomiting. Dieulafoy lesions, so these are arteries of the GI tract that actually protrude through the submucosa, and because they're protruding through the submucosa, they're getting hit by that acid, and this can cause intermittent but massive GI bleeding. I've never actually seen this one myself. And then, of course, bleeding that is not bleeding from the GI tract, so ear, nose, throat sources. People get a little confused with that. Sometimes they'll complain about hematemesis, and then you find out that really they're coughing and then spitting that blood out. So on the diagnosis side, yeah, really good history, at least an appropriate history. So you characterize the bleed. What color is it? What's the amount? How often are you seeing blood come up and out? This is sometimes hard for people to verbalize, but you kind of have to really push them to help you get a good understanding. Have they had these in the past? Do they have prior bleeds? I saw a guy get coded for almost 4 hours with multiple rounds of massive transfusion protocol. That was an upper GI bleed. He was an alcoholic that had varices. And the thing was, this was not his first rodeo. It was the, I think, second or third time he had gone through this process. So knowing ahead of time that they've had a poor experience, I'll say, is good to know. And then push on substance use. So you got to remember medications as well as alcohol. I think sometimes we tend to um, anchor on the illicit drugs or on the I guess recreational because alcohol is not illicit, but that we tend to anchor on that. But talk about how much aspirin do you use, how many Motrin have you been taking, and then I don't know. So this is pretty dependent on who you talk to. If you talk to the GI docs, they seem like a stool guaiac is absolutely not in needed for any reason. Um, but it's probably right on the test. So if you're taking an exam and they say, how are you going to differentiate? But it's probably going to be a stool guaiac. I feel like I've been doing a lot of them. I don't know. I don't know. Still, still out on that one. So things to watch for: hypotension, tachycardia, angina, syncope, weakness, confusion, and of course cardiac arrest. So let's kind of go in order a little bit. You're probably going to get more of a pulse pressure difference before you get the hypotension. But remember that vital sign changes are a late finding on the hypovolemia, like the shock classification. So if you want more on that, you can go visit the ATLS because this is in a way a trauma, right? you're having massive amounts of bleeding, even though it's not on the outside. It's not because of, a knife wound or whatever. It is a lot of it is the same concepts. So it doesn't matter, if they go into arrest, it doesn't matter how hard you push on their heart. They don't have blood to move around. So it's the same overall idea. So when you're doing your physical exam, you're probably going to be doing the abdominal exam that we talked about in the approach to abdominal pain. But also, you need to take a look at their vomitus, and you need to take a look at the rectum. Sometimes people complain about bright GI bleeding out the rectum, and you take a look, and you can see it. It's all around their anus. Um, but take a look in their mouth. Do you see any black? Do you see any red? Do they have that decreased pulse pressure, or the tachypnea? Those are the early findings. Remember, old people bleed and they bleed often, but you know what else they do? They take beta blockers. And if you're taking a beta blocker, you're not likely to get either a tachycardia or that initial, sometimes hypertensive response to the tachycardia. So consider whether or not there is a blunted response in your vital signs. Take a look for signs of liver disease. Do they have jaundice? Do they have hepatomegaly? Sometimes you can actually feel that. Do they have scleral icterus? Things of that nature. You're looking for signs of coagulopathy. Or do they have petechiae? Do they have bruising and multiple levels of healing? Uh, Checking for lesions, cutaneous macules, telangiectasias, all those signs of liver pathologies and bleeding pathologies. And then, of course, doing ear, nose, and throat. Really just taking a look inside their mouth there. So what kind of labs are you going to get? Get the type and cross match. Order it early and order it often because you do not want to be behind the 8 ball waiting for a type and screen so that lab releases the blood. Get the CBC. Plan on ordering repeat H&Hs down the road if you think you've got a GI bleed, even if that first CBC is normal, and especially if you're planning on keeping them anyway. Get the H&H because that might not be normal anymore in 4 hours, 6 hours, 8 hours, 12 hours, whatever. But then you're trending it, and it also sets up the people for success upstairs. Get the BUN and the creatinine. Remember, if they have a GI bleed, as that blood goes into the GI tract, it's going to elevate their BUN because that's all the protein getting digested. So you're going to have an elevated BUN to creatinine ratio. I think the number is 30-1. BMP, CMP, you're probably going to get a CMP because you're thinking about liver enzymes and things of that nature anyway. There's probably an abdominal pain portion. PT-INR, or PT-INR, PTT, get the whole coag panel. There's a good chance these people are on thinners or they're having some kind of liver pathology. So you're going to want to run that anyway. Lactate, makes sense, right? You're going to be checking for, signs of ischemia. Get that with your lactic. And then, all right, so the book says endoscopy. The thing is, at least in my shop, it's not going to happen. It's not going to happen in the ER. They're going to get admitted. You're at least going to get them into observation, and then maybe endoscopy happens the next day. It's not a bedside thing that is very realistic the vast majority of the time. And if it's bad enough that you need GI to come in stat, they're probably bad enough that you need to stabilize them before they're going to be able to do anything anyway. Remember, there was this idea that doing a nasogastric tube and then if you pull out the contents of the stomach and it's not blood, then it's on an upper GI bleed. But the thing is, that's been proven to not be conclusive. You can also use an upper GI guaiac card. We don't have these in my shop. You can do a lavage if needed, but again, these things don't seem to be. They seem to be test appropriate, but not real world appropriate in my experience. So one of the things you have to think about is risk stratification. The things that are very low risk, right? Like they're less than 60 years old. They don't have major comorbidities. There's no history of red hematemesis. Maybe there's just some streaking. There's no hematochezia. They have a negative nasogastric aspirate. Again, that's a book thing. They're hemodynamically stable. They're not hypotensive. They're not tachypnic. They're not tachycardic. They don't have that increased pulse pressure. And you get relatively normal laboratory studies, especially that BUN being all right and that CBC being all right, maybe even ×2 if needed. High risk, advanced age. Anybody who's over they say 60 here. Yeah, they're high risk for lots and lots of things, and these people get super sick, especially if they have comorbidities or they've had a prior endoscopic or a transjugular intrahepatic portosystemic shunt procedure. I feel like a lot of times you can maybe find this in someone's chart, but it's not been often that they've thought to provide that in their history when I'm asking about like previous procedures and things like that. Red hematoemesis is a concern. Hematochezia or melena, melena, positive nasogastric aspirate. I mean, so if it's negative, it's not necessarily negative. If it's positive, it's definitely positive. And I've had this happen where I was honestly, I had this guy who was totally obtunded. He was a massive stroke. I was getting ready to push the TPA, or the TNK actually at our shop, and they had put in an NG tube, and there was a little bit of blood at first, and we're like, all right, maybe a traumatic NG insertion, and the nurse was like, oh no, it wasn't traumatic. There's no way. It went in super easy. I'm like, all right, let's watch. And it was coming up clear and like cool, no signs of GI bleed. Let's go ahead and do it. And I had everyone at the bedside. We had just gotten his blood pressure under control, and then that NG tube turned bright red right in front of our eyes, and we did not push the TNK. Other high risk things, hemodynamically unstable. Again, late findings in the shock classification would be the hypotension, the tachycardia, the tachypnea, and then first and foremost, like the first thing you'll see is that narrowed pulse pressure. And then, of course, abnormal laboratory studies are high risk. So treatment. Oh, I've added a. That's one of the few ones that I added an animation to. So blood transfusion, right? So you don't want these people to code on you because if they do, you got nothing to be pushing around anyway. You want to correct their INR or their platelets if they're under 50. For sure, you're going to do pantoprazole or omeprazole. So here in the book, it said omeprazole 80 milligrams IV bolus and then infuse 8 milligrams an hour. At my shop, we do pantoprazole 40 milligrams IV bolus, and often the infusion, again, kind of practice specific. Seems like the data is a little bit out on that, but as far as tests go, I would start an infusion. If you're thinking about a varices or something along those lines, then you're going to do octreotide 58 micrograms bolus and then again infuse. And then antibiotics. Antibiotics are one of the most important things because that's the one that's actually linked to improved outcomes and improved mortality. So ciprofloxacin 400 milligrams IV or ceftriaxone 1 gram IV. I tend to go with ceftriaxone. I'm just a little bit more comfortable with it. I use it more often. It's one of the antibiotics that we use frequently. Ultimately, of course, they're going to need endoscopy. If they're real, real bad, you're going to have to balloon tamponade them. I've only seen this done once so far, actually, and then down the road surgery. All right, let's switch over to lower GI bleeds, the other half of the track. This is what I feel like I see quite a bit more often. Although you never really know, right? Like it could be an upper GI bleed that's not actually just coming up the upper side. So lower GI do occur more often than upper GI. You're going to see hematochezia, which is like bright red or maroon, but 10% of these are brisk upper bleeds. And then melena, which is dark or black colored, that is probably an upper GI because it's had a chance to be digested by the time it comes down, right? So that's why it's dark or it's black. The in my own personal experience, I see a lot more of the dark or black colored stool, the melena, than I do hematochezia. I've only seen hematochezia maybe a handful of times. So common causes, diverticulosis is the most common cause. It's painless. It's just the erosion of whatever artery is penetrating that diverticulum. And 90% of these resolve spontaneously, but it's going to recur in about half of patients. Vascular ectasia or AV malformations or angiodysplasias of the colon, and again, these are chronic. These increase with age. They're not super emergent necessarily as long as the bleeding is controlled. And then hemorrhoids. Hemorrhoids is actually one that I see quite a bit. If they're under a certain age, it's probably going to be hemorrhoids. It's the most, common cause for like younger patients. And it's kind of nice because these are pretty easy dispos. They talk about, that they're concerned because they had blood in the stool, maybe once, maybe twice, maybe for a couple of days. And then the thing that they talk about when you ask them to help clarify, often you'll get them saying that, well, it's like my poop is streaked with blood. Actually, in my population, they say boo-boo a lot. Like, when was the last time you defecated, sir? Well, I haven't boo-booed for a couple of days. Like, you are a grown man saying boo-boo. Uh, but so then you do a DRE, you find that hemorrhoid, you'd be like, all right, you're good. Ischemic colitis, mesenteric ischemia. If you've got colitis, you're predisposed to ischemia, and this really happens in those poor circulation, those watershed areas. And if you remember, those are on the flexures where the blood supply doesn't totally overlap as well. This is diagnosed by endoscopy, and the issue is that this leads to bowel necrosis. So, and I've seen it before with SMA, or actually I've had IMA too, that you get a thrombosis or an embolism in that artery, and that leads to diffuse colitis or ischemia. Another option would be like mesenteric venous thrombosis, kind of the same concept. You can think of it like a heart attack of the gut, right? You get in a blockage in one of the major blood supplies, and things just start dying. And as they die, they slough off, and it comes out as a GI bleed. And another one would be like a non-occlusive mesenteric ischemia. So again, so going through like the approach or whatever, history, people love to tell you about their poop, especially if they're old. They will tell you all kinds of information about their poop. Uh, so look for signs and symptoms of hypovolemia. So, again, we talked about the vital signs being kind of late findings, but you might get some lightheadedness, shortness of breath, chest pain, things that come along with just not having enough blood or oxygen to get pumped around, right? People with previous GI issues are at a higher risk. Make sure you ask about their medications, and then, you know, look like poop. Is it what does it look like? On the physical exam, again, signs of hypovolemia, and I know I've been pushing on this a lot, but we see a lot of ECF type patients, older patients. So signs might be masked in people with beta blockers or calcium channel blockers too. Look for that cool, pale skin. When you're thinking about lower GI, if they got a tender belly, think about something inflammatory, right? If it's not tender, think about something in the vasculature. Dying tissue doesn't. Um, yeah, dying tissue just doesn't really tend to be tender. If they've got more of a colitis type picture, all that inflammation should hurt more when you touch it. For labs, obviously, again, the CBC, the electrolytes, the coags, type and screen, and then again, that BUN creatinine ratio. And here, yeah, I do have it over BUN to creatinine greater than 30 to 1. So, and consider repeat H and H's as necessary. Imaging, you can skip the x-ray because honestly a CTA is ideal. Going back to a previous lecture when we talked about abdominal pain, you might want the chest x-ray just because you can usually get that faster if you're concerned for something like a free air. But as far as x-ray of the abdomen, like there's essentially very little utility for that anymore unless you're on a pathology that's like the only thing is really an obstruction of some kind. For treatment, obviously you're going to resuscitate them, right? Oxygen on the monitor, 2 large bores, fluids, all those things. But the thing is, you actually need to replace with blood, right? So depending on where you're at, but most places I've been at, it takes a while to get blood. So I'll get them started on a couple of, even a couple of liters of fluid, like a normal saline or LR. I'll have them pressure bag it. Let's really get that blood pressure going. Let's use what they got as for now, but we need to get the blood process in place. You got to correct the coagulopathy. So if they got an INR greater than 1.5 or platelets under 50, you need to do that. You can consider an NG. Maybe this is an upper after. You could probably want to decompress the bowel. Or there's a good option or a good chance you want to decompress the bowel. But remember, a negative aspirate does not mean that there's not an upper GI bleed. Call surgery, call GI, they probably need a scope. All right, so approach to the bleed. Where do you start? Hey, someone comes in and they're saying, I'm bleeding out my GI tract. So upper GI, try to differ. Okay, either way, try to differentiate, right? Is it upper or is it lower? Do they have hematoemesis? Do they have coffee ground emesis? Is there melena or black tarry stool? Make sure it's actually coming from the GI tract, though, right? They might talk about, if it's coming out bright red and frothy, you know what? That's actually probably pulmonary. And again, I've had this before where people say, "Yeah, I'm throwing up blood," and then while you're standing there, they start coughing and they spit out bright red, frothy sputum. Like, well, how long have you had your cough, sir? Oh, it's fine. I got COPD. And then if it's dark red, if it's brown blood, but you got some nausea, vomiting, then you're really thinking GI tract. As far as lower GI, again, hematochezia, bright red, or maybe maroon stool. And these tend to be a little bit more chronic. You're probably looking for signs of hypoperfusion, right? On the physical exam, again, the tachycardia, the hypotension, the pale conjunctiva. I really like to look in the eyes for this. This is a very easy place to see it usually, especially if I've got like an altered mental status that's coming from ECF where they're not able to provide any additional history, and you know that ECF paperwork and that report is usually not very good. Take a look in their eyes. Take a look at their conjunctiva. Try and take a look in their mouth. Do they have signs of dehydration? Are their mucous membranes wet or dry? Is their tongue nice and swollen, or is it shriveled? Right? Roll them. Check the butt, especially ECF. You got to be checking for a sacral DQ anyway. Labs, again, CBC, electrolytes. Get the glucose right away at the bedside. BUN creatinine. Check that ratio. Check your coags. Check your LFTs. Get the type and screen because you might be needing blood. And then just plan on repeating that H&H as necessary. Again, I like the chest x-ray. I like the chest x-ray because often I can get that right away. If I need to rule some out, some like serious badness, uh, I can get that, and then I'll get the CTA when it actually happens. But realistically, like the CTA is what you actually need. Okay, you got to make a plan. Is this an ABC patient, right? Are they crashing, or are you considering that they will, right? Which way do you think that they're headed? Uh, you're gonna give them 2 liters, but really they need blood. So consider if you need massive transfusion protocol. How brisk is this bleed? If they got an INR above 1.5, think about FFP and vitamin K. If they have a platelet under 50, guess what? You give them platelets. Call GI, call surgery. They're strict INO. You're going to transfuse them, and then the IV pantoprazole. We were kind of talking about before. Some of the books still say omeprazole, and then if you think it's varicocele, octreotide. All right, these are my references. Thank you very much for listening. That was the approach to just GI bleeds. Looking forward to talking some more GI stuff with you soon.